wall of the heart, but also the wall inside the heart that separates the right-sided from the left-sided chambers that we call the septum. And that's called the left anterior descending, or we refer to it commonly as the LAD. You'll hear people talk about the LAD. There's one or two typically decent-sized branches that come off of the LAD and project towards the left side of the heart. I'm showing you a two-dimensional image here, but imagine a three-dimensional heart. They're projecting this way. And then you'll see this one here that I've sort of drawn the contours of with dotted lines. That's because obviously this is how it shows up in two dimensions, but what is actually happening in a three-dimensional heart is this branch here, called the left circumflex, is circling leftwards and going to the lateral and back walls or posterior sides of the heart. So that's the circ system coming around there. So we think of these as like rivers that irrigate three major myocardial territories. The right-sided territory, which includes the inferior wall and, in most people, some of the back wall and some contributions to the lateral side. The front territory of the heart, which is the LAD, and the left lateral and posterior part of the heart muscle, which is irrigated by the left circumflex system. You'll see I've written OMs here. These are just designations of major branches of this circumflex system called obtuse marginals. So when I think about somebody who has coronary disease, the first question in my mind is, how many of the major myocardial territories are affected? Not so much how many vessels, but how many territories. And so in your case, it is true that all three major myocardial territories are affected. It is also true that there's probably been an order in which these have developed. I believe your right-sided downstream disease started quite some time ago, because this one right here, the right posterior descending branch, is 100% blocked. And that doesn't happen in a person who's had almost no symptoms and maintained a very active lifestyle. That won't happen except extremely slowly. We're seeing the end of a long-standing process. Why? I can't say. But we're seeing the end of it. And so for quite some time, this heart muscle downstream from this right-sided posterior descending branch has not been getting any blood flow from the right-sided posterior descending branch. Where it's been getting it from is what we call collaterals. So blood flow that gets redirected from other adjacent or surrounding vessels to this myocardium. And so you never really noticed that. Never had a heart attack. There's nothing on your EKG that suggests you've ever had an infarction. By the way, you are not diabetic, correct?
No.
Okay, so again, in diabetics, we worry about silent ischemia. People don't get angina or chest pain because in diabetes, the nerves don't really communicate that information as effectively. Not an issue here. So clearly, this has happened very slowly, happened quite some time ago. I think if you look at some of the other areas, there's disease in the mid portion of the right main. There's some disease in the mid portion of the left circumflex. And then there's disease in the LAD proper. If your coronary disease has anything to do with your fainting spell or your mechanical fall, it's almost certainly going to be because of the LAD lesion. Because this is the one that tends to compromise blood flow, not only to the biggest territory of heart muscle, but probably in doing so also has compromised the collateral blood flow to this territory here that was probably the original one that was compromised in the posterior descending branch. Okay? Now, I say if because there's no real way to know, and truly, you've been active and doing fine since. And also, the defect that was described in your nuclear med scan talked about the inferior wall having a reversible. Okay, this is where we get into some nuance. I'll try and describe it this way. The power of nuclear medicine imaging of the heart to demonstrate, either in a resting or an active state, deficit in the quality of blood flow principally hinges on two things. First, the difference between the demand for blood flow based on the demand for oxygen in a physiologically stimulated or stress state versus rest. So that differential, you could be fine at rest, but if your heart muscle's challenged, you can't deliver as much blood flow to the heart muscle as you need. Therefore, you see a perfusion, we call it defect or deficit. Fancy word for there's less blood flow to that muscle and therefore less oxygen than there should be. The second piece is that there is a sufficient opportunity for there to be an imbalance between the supply and the demand of oxygen. If you have what we call balanced ischemia, you may not see that on a perfusion study, which is why even in instances where you have symptoms or you have an event that makes you suspicious, in the face of a normal perfusion study, nuclear medicine perfusion study, you may still elect to go forward with a catheterization study. Because the gold standard for demonstrating blockages in the heart's blood flow or the arteries is the catheterization study. The squirt the dye under X-ray, watch the blood flow through the vessels and see whether there are areas where the column of blood flow is acutely or severely narrow.
That's not the angiogram.
That's the angiogram.
Oh,
that's
that was
correct.
the angiogram. Okay.
Yeah. So we call them catheterizations or angiograms. Same
Just-
concept.
okay.
Yeah.
Thank you.
All right. So that's kind of what the lay of the land here is. Now, let's talk about what are the options. So there are options to go after different targets. A bypass is constructing an alternative route for blood to flow, blood directly from the aorta, and directing it to a place on the heart muscles, blood vessels or inflow, that is downstream from where there's a blockage. So you're basically circumventing the blockage. Stenting or ballooning works from inside the vessel to open up a blockage and create a greater degree of permanence or durability to that openness so that you could solve the problem from inside the vessel rather than from outside of the vessel. Does that make sense? That's the contrast between the two. It is not impossible, but it is more difficult to deal with a complete blockage like what you have here with a catheter-based approach or a stenting approach. And that makes sense. Now, if we were to just take a surgical approach to this and say, we absolutely believe that bypass surgery is the best, and so where can we add value? Well, you could land a graft, a bypass graft, beyond this blockage here in the PD. You could land one here in the right so that you could get blood flow to the PL as well. You could certainly land one here or here so that you get blood flow to these branches beyond this blockage.
From aorta.
Yeah. And then you would land one here potentially in the LAD. Certainly that would be. And some people, if you had diagonal disease, I couldn't really tell how bad it was, but let's just say, because you mentioned the number 5, right? So that's 1, 2, really 3, 4, 5. So yeah, quintuple bypass, yeah, sure. I mean, if you look at this, you can see where you might land those grafts. But let's talk about where it's actually valuable to land a graft and whether the only way or the best way to restore good blood flow and a balance between oxygen demand and oxygen delivery, or blood flow demand and blood flow delivery, is surgical versus, because nowadays we have drug-eluting stents. These are stents that when placed in a short segment lesion in a large blood vessel, the data shows are certainly the equivalent and probably superior to vein grafts like this. And where would such stents be easy to deploy in your situation? Well, certainly here. Okay? Potentially here. Not here. And then the real question is, what about here? Is it okay?
I'm sorry, I want to FaceTime
Oh, sure.
sister because
That way she can see in real time.
I'm a little overwhelmed by this. I just need to FaceTime you.
You can probably drop that there.
How do I reverse? Okay, sorry. So I'm gonna
reverse it in the picture. I got to turn the picture around and I can see what's going on.
Excuse me, just
but I don't want to turn the
second.
camera around.
Hello?
I don't want to turn the camera around because then I can't see what you're looking at.
Yeah, no, just show me.
Okay, here, sorry. I can do this with the kids and then suddenly I'm having a... Are you able to record on your end? I'm sorry, Doctor. I'm just a little overwhelmed, so I feel like I need to
take your time.
Let my sister see this.
When you were saying the drug-eluting stent and you were saying could go...
Saying, from a purely technical perspective, even perhaps the LAD. Now again, the reason that I wanted Dr. Spies to weigh in here is a lot of conceptual knowledge and a lot of experience in looking at what could be stented or what should be stented. But I always like to have people who actually do the stenting weigh in, right? I don't need them to weigh in on the surgery. So that's why that I thought was important. But let's talk about what value surgery could have for anybody and specifically for you. Because I will tell you that the only way I know how to practice is when I look at a guy like you, I say, if this were my dad, knowing what I know about him and about cardiovascular medicine and surgery, what would I want for him? And I would not want you to have a quintuple or a quadruple or even a triple bypass, unless the areas where I think we could deploy short segment, large volume, drug-eluting stents are somehow technically not reachable, or there's a reason why, from a technical perspective, deploying a stent in that space is problematic. But conceptually, and I don't mean just conceptually, I mean based on the data that we have, what we've learned is that drug-eluting stents here and here, if properly deployed, solve the problem as well, if not better, than a vein bypass. And so the only reason, and this is where I'm going to differ from the input that you've had, but I believe I differ with the data on my side. The only reason for us to consider any kind of surgery in you is the LAD lesion. Because we know two things about the LAD lesion. It's the most dangerous lesion you have and may have played a role in the event that you suffered, fortunately without any permanent damage or major injury. But we also know that if you can surgically revascularize the, and that's a fancy word for construct a new route for blood to flow, a bypass to the LAD using the artery that we would take down from the undersurface of your chest wall on the right side of your sternum, called the left internal mammary artery, the lima. We know that that particular form of bypass delivers a benefit to a patient that is beyond the benefit of any stenting strategy. And that has been shown conclusively in the data. We know that to be the case. And the reason for that is the lima is an artery designed by nature and God to carry high pressure blood flow just like your coronary arteries are. We know that it has a pristine origin from your left subclavian artery. That means that all we need to do is redirect the downstream end of it. And then blood flow that would normally go to your chest wall through an arterial conduit now flows to the LAD and bathes the biggest myocardial territory that there is. And the one that is involved in sort of the widowmaker lesion, takes that off the table. And it does so more durably than a stenting strategy. Now, let's understand that although you don't look it, you're 80 years old. And so what's probably in your head, and would be in mine too, is, okay, well, I understand this Lima to LAD solution is better than any stenting strategy. And I understand that if I were 60, or maybe even 70, there would be material benefit to me having a Lima to LAD bypass based on the fact that I would be free of the need for future interventions. Which, if you have a stent deployed in your LAD, you're not free from, because there is an increased opportunity for, based on just the way stents behave, and particularly in that location, there's an increased opportunity for needing more work done in the future. There's also...
What time frame is that? Is there...
Well, so typically it's within the first 5 to 10 years. So nobody's, I tend to think in terms of 100-year lifespans nowadays. Maybe that's just wishful thinking for me.
That's exactly what I was thinking as well.
But, 80 to me, in a person like you're chronologically 80, but you're not physiologically 80. Because I know a lot of 60-year-olds that are in worse shape than you and do less exercise than you. Right.
Yeah, look at his beautiful hair. And
it is. I'm
my
jealous of that.
Granddad, he lived to 99.
Yeah. So my feeling is that actually, in your case, we're aiming for a 20-year solution here. And in that regard, the Lima to LAD bypass does enjoy statistical data-proven advantage over any stenting strategy. It enjoys that advantage, whereas the vein grafting strategy for the other vessels does not. That's why I'm saying the total surgical solution here is unnecessary and probably not the best solution. Now, there's one other component about the Lima to LAD, which is you can do this revascularization without ever going on the bypass pump or arresting the heart. You do an off-pump bypass, which I do very commonly with my colleagues, and this gets back to why I was thinking in multidisciplinary terms. When I have a patient like you, I say, look, I think I have between the two of us, for the LAD problem, I have the best solution. And I can do it without stopping the heart or going on bypass.
Oh.
But for the other vessels, I think Dr. Spies has the best solution. So why not combine our solutions? And the way that usually works is I do an off-pump, single vessel, left internal mammary artery to left anterior descending coronary artery bypass. You recover fully from that. You go home, all your own activities of daily living and all that is fine. You're just letting that heal. And then at some point thereafter, typically it's in the 4-week range, they come back, somebody like Dr. Spies comes back and puts stents in these other vessels. And this one, I would leave alone. I would do nothing about that.
Okay.
Not just because you're 80, but because that's been gone a long time and you never had any problems. The only reason you have any problems is because what used to compensate for this is now threatened by the lesions that I've drawn in these other vessels, right? Because there's not enough to go around now on that basis. So, net recommendation from me to you, based on the principle of what would I want if you were my dad, if you were willing to undergo a sternotomy, off-pump, Lima to LAD bypass, I would say the data-driven best solution, the optimal solution for you is an op-cap Lima to LAD, followed thereafter by a very good interventional cardiologist putting in stents.
How many days apart?
Usually it's about 4 weeks apart. Yeah. Because I'd like you to have this wound pretty much healing together before you sit on the angiogram table. But the truth is, then when Dr. Spies or somebody like him comes in and does these other interventions, he's working with a lifeline, and so are you. While he's putting balloons and catheters in these other vessels, the rest of your heart is getting arterial blood flow from the bypass. So that would be the plan. Now, the alternative, the backup plan, if you think to yourself, you know what, I would... As long as they can stent the LAD, I'd rather they do that. And if they have to come back and stent it again in the future, whatever, we can do that. Then you stent everything. But you got to be in the hands of a really good interventional cardiologist, and you have to understand that that interventional cardiology procedure, despite not opening your chest and so forth, is actually not, it's not insubstantially risky, because you're asking somebody to go in and blow up balloons and stents in all of these vessels at the same time when you've got compromised blood flow going into each of those vessels. See, if I go in here and I cut this vessel and I put the lima to the LAD there, I'm not disturbing anything else. Everything else is status quo. Then once that's there and you've got that blood flow going in, then Dr. Spies or somebody like him can use that to do his stuff, and he can be pretty aggressive because your heart's got a lifeline. It's got an alternative inflow of blood. So he can blow balloons up all he wants, pretty much.
The Lima LAD part of it, you said you don't have to stop the heart. Wait, is that when you open the chest and everything?
You do have to open the chest.
You have to stop the heart.
Don't have to stop the heart.
No pump.
No pump. No cross clamp of the aorta. No arrest.
You're still opening up the chest.
But you do have to open the chest.
Thank you. And
What do you do with the heart being pumping? And to do that, I don't know.
Yeah. So you have to be good at sewing on a moving object. But what I do typically is I open the pericardium, the sac around the heart, and I take the left-hand side of it when I've opened it like this, and I bring it up onto the chest wall so the heart gets rotated like this. Then I typically put a wet sponge behind the heart to lift it up even further. Then I put the patient with a head down position, so we're preserving blood flow to the brain during this entire time. I put a temporary pacing wire on in case we have any problems. I can take control of your heart rhythm. And then I dissect the area. I've first obviously taken down the lima. I dissect the area where I'm going to make the opening. And then typically I put these silastic, almost rubber-like material upstream and downstream from where I'm going to make the hole, and just put a little tension on it. I don't totally block the vessel. I don't mind blood flow going through.
So when you're sewing the construction of the myocardium is not
Right. So I've tried to. I'm letting the rest of the heart do everything that it does, but I'm trying to just immobilize the little area where I need to work. And I've got a little device that will come down on the surface of the epicardium like this with suction cups. I apply suction to it, and it sort of stabilizes it there. There is some movement still. Sometimes I can put a little shunt inside the vessel, so while I'm working, there's still blood flow going downstream, and I'm just sewing around the shunt. And it takes about 12 minutes, 12 to 15 minutes to sew that connection. And then at the end, I just take everything away and put the heart back where it was before and close the chest up. Might have to leave some chest drains in, but those come out at the bedside afterwards.
What happens if I don't have that artery? Do you take the other artery?
Oh, so that's an excellent question. We have 4 implants. Yes.
Put the stent. Oh.
Yes. So I have a number of them. I've over the years I've recruited
You
a
do all
bunch.
your procedure in one place?
No,
or different
I do it
hospital?
in 3 places, but on any given week I only operate in one place. So tomorrow, for example, I'm operating in Mountain View.
is that the El Camino Hospital?
That's at El Camino.
Okay.
Next week I'll be operating here. And when I do heart transplants or heart failure cases, I do them in San Francisco at CPMC. But you don't need to go all the way up there. So I think what I'd like to do, or what I'd like to suggest, is this. First of all, let me tell you how grateful I am you came all this way to see me. I really appreciate that.
Thank you for accommodating us, Doctor.
Not at all. And what I'd like to do is I'd like to be able to show this, if you'll let me keep it, to Dr. Spies, and definitively get his technical impression about these other areas where I think we could add value, not surgically, but with a drug-eluting stent. I'd also want him to challenge me here, because not all LAD stents are the same. You know, in some areas, if you've got a really short lesion in a nice, big, fat part of the vessel, and the rest of the vessel is fine, man, I'd have to scratch my head and really wonder whether the lima is really worth it at that point, because it's just... On the other hand, if he would have to put stents from here to here, then I would want you to have the bypass because I know we could do a better job. Right? So it's about tailoring it to you. So I think what I would say is the maximum level of invasiveness that I am expecting is appropriate to your case is the off-pump Lima to LAD bypass, followed thereafter in a phased fashion with stent placements elsewhere. The minimum could be stents everywhere, and likely in a phased fashion. They bring you back twice so that they don't do all that, try to do all too much at once, right? So that's what I would recommend to you. If you will allow me, I'll share this with Dr. Spies, and then I will have my man Mitchell, with whom I think you communicated to set up this appointment, get back in touch with you, and we can have a follow-up video visit or just a regular phone, whatever you prefer. And I can let you know what Dr. Spies said, and we can sort of refine the recommendation and come down to, what I consider to be the best option, and make that recommendation to you definitively. That sound okay?
Yeah, that sounds very clear to me. Yeah.
Okay.
Yeah.
Do you want to
How
keep
long
this?
that graft is gonna last?
The graft?
Yeah.
The data right now shows that pediculed left internal mammary artery to LADs that were well constructed and worked from the beginning, when they are assessed with an angiogram, 15 to 20 years later, 95% of them are still working. So when you're 100, it'll still be working.
How about the stent?
Stents, we have less data because they haven't been studied for as long, but we have enough data to know that the stents beat the vein grafts. Because vein grafts, within 5 years, 20% of them are closed. Stents, 80% of them are open for sure. And so this is one of the things I'll be asking Dr. Spies to comment on. Okay. Is this of value to you? You want to keep this?
I would
You don't
like
have
to keep
to.
it. Thank you, doctor. I do appreciate it. Thank you.
You have any questions?
Hmm?
You have any questions?
Me?
Yeah.
I cannot say any questions.
Oh.
No question.
Maybe get a card for Dr. Spies.
Oh yeah.
So I can get the name,
Let me
spelling
do
of
this.
it.
Give me one
Do I
moment.
have to see
And,
him?
Let me.
I want to.
or
Is
no?
it her?
Give me one moment because we may have an opportunity.